This is Heal Your Mind, Heal Your Body with Dr. Schuyler. Discover how your thoughts manifest disease and what you can do about it. Here's your host, Dr. Schuyler.
Hello, beautiful souls, and welcome back to Heal Your Mind, Heal Your Body. I have an amazing guest today. Her name is Dr. Safder. She is the director of Neurogastrointestinal Motility Disorders at Arnold Palmer Hospital here in Orlando, Florida. So she is a pediatric GI. Welcome, Dr. Safder.
Thank you so much for having me. It's an honor to be here today with you.
I want to explain to people how I met you. You actually began my journey into mind-body psychology to really specifically get into GI and then eventually AI. So I want to tell people how we met. It started with what I call the miracle patient. And I get a phone call back in 2017. You introduced yourself and you had the 17-year-old pediatric patient who had serious, severe GI problems, and you were looking for hypnotherapist. And I remember just saying, okay, teach me what do I need to know about GI disorders? Just teach me what you can. And I wanted to ask you, actually, this whole time I've known you, I've wanted to ask you, what was your perspective? Like, what did you go through clinically as a physician?
Right. So our miracle patient, as we're going to call her for the sake of this podcast, you have patients. Every patient of mine has been a learning experience for me. You always learn something from your patients, and you go through traditional training, and you gather your own experiences, and like I said, every patient is unique. This particular young lady who we were talking about was one of the most challenging cases that I had taken care of. And she was challenging for many reasons, mainly because her symptoms were so refractory to our medical, diagnostic, and therapeutic intervention. So like any patient who comes and sees you, you start with a good history, a good physical exam, and you just really listen to the patient, right? And so this young lady had a history that there was a lot in her history, and you try to piece out in terms of like, when did this exactly start and when did the symptoms get worse. But she really presented with a lot of GI complaints, a lot of GI discomfort, pain, nausea, feeding intolerance. And so you get your history, you collect your data, you do an exam, you look for things on the exam that hopefully will guide you. And then you mount into a diagnostic workup. So you start doing testing and you're looking for things. And the reason why I said she was so challenging is because her diagnostic workup was very extensive and very thorough, because we really trying to find the why in terms of why she was struggling so much, especially with her inability to eat and tolerate feeds, and the pain and the discomfort, and really her quality of life that was struggling. With each step of a diagnostic workup, you make an assessment and you try different treatment plans, right? I'm trained in the traditional, allopathic medicine. And so, of course, we have sort of an algorithm of how you would approach such a patient. And you try medications, and then you try different feeding strategies and different feeding techniques. And what was perplexing is it didn't matter what we did or what approach we took, we were not making any progress, to the point where her nutritional status was really struggling and suffering, and we were having to go to more artificial means of nutrition delivery, whether it was tube feeds or what we call parenteral nutrition, which is through an IV, which requires a central line access, which really just adds to the complexity of a patient's management. And with every intervention, like I say in medicine, sometimes less is more, because the more you do, the more side effects, the more complications. Medications have side effects and complications. And so we were really struggling with the more we did. Instead of seeing results, we were just seeing complications or problems that were coming from the intervention. And really, she wasn't getting anywhere, or we weren't seeing progress, and we were really sort of stuck. You ask for second opinions because not everybody has the answers to everything. So, I'd ask for second opinions, and everybody's sort of like scratching their heads. And you sometimes just have to kind of go back to the drawing board, right? You understand that, especially with medications, and for some patients, the side effect profile is so heavy that you're looking for something that's maybe a little bit more holistic and really kind of goes to the core of the matter in terms of where we can help them. So, like I said, just going back to the drawing board and taking a step back and being like, look, this is really, she fell into what we would call disorders of brain-gut interaction. Back then, the terminology has changed over the years. They used to be called functional GI disorders and disorders of brain-gut interaction. And those disorders have a biopsychosocial model or premise. And I felt like a lot of the psychosocial part and how the nervous system plays such an integral role. There's such a talk between brain gut that had not been addressed for her. And you need somebody, who's willing to recognize that we have to try every modality of treatment. And that modality had really not been explored for her or optimized for her. And I needed somebody who really knew what they were doing to come in and help her. And that's where you came in. And I picked up the phone and I called you and I kind of gave you the backstory. And I was like, I really need your help, Skylar.
Well, that was a phone call that changed the direction of how I took my entire practice. What was her diagnosis? What was her presenting and what was her diagnosis?
So her diagnosis was essentially she had chronic refractory abdominal pain, nausea, feeding intolerance, and subsequently gastroparesis and chronic abdominal pain for her, there was the nausea vomiting component was pretty heavy in part of her symptomology. So that's what we were dealing with. And she fell into, we have different ways of, describing these disorders. So motility disorder, I guess would be a nice way to summarize it. So for, our audience, motility, GI, gastrointestinal motility is essentially how things move through your GI tract. So our GI motility helps transit food that we chew into our stomach. Our esophagus transports it to our stomach, where a lot of the breaking down of the food occurs. And then those broken down nutrients are sent into the small intestine, where absorption of the nutrients occurs. And then the waste products enter our large intestine, where absorption of water and fluid contents occurs, and then the wastes are excreted. So it's a normal physiological function that all of us perform all day, every day. And, we're blissfully unaware that our GI tract does this complex, processing. But essentially, that's how that's what GI motility. So any dysregulation in that normal physiological process, where either the motility is altered, delayed, accelerated, either any kind of dysregulation can cause symptomology. And if I may, the gut is so complex. It's so complex because there's the physiology of the gut, but the gut also has a brain, which is very interesting, and I'm sure we'll talk about that a little bit more because it's all under neural input, telling the gut what to do. So motility is essentially under the neural control, or the gut brain essentially controls gut motility.
So when I saw the miracle patient, I remember, was it an NJ tube? Which she had a tube. Yeah. Was it NJ?
She had an NJ, and then subsequently she had a G tube, and then she had a GJ tube, a gastrojejunostomy tube. Yes.
It was a GJ tube, and that, I'm going to do it in layman's term, that goes to the very base of the lower section.
So GJ, so the G there's a port that goes through your stomach, the gastrostomy port, but it ends the J, jejunostomy. So it courses past your stomach, past your duodenum, and goes into your jejunum, which is the second portion of your intestine. So kind of kind of going far into the small intestine where a lot of nutrient absorption occurs. So she had a gastrojejunostomy tube. Yeah.
So when I met her, she had that tube. And she explained to me because every time she ate, she experienced so much pain, even if the tube was placed higher up, no matter what. It was so much pain that she couldn't handle it. Is that correct?
Correct. Yeah.
So what happened when I met her, she hadn't eaten solid foods. I think it'd been 3 years before she could have a full meal.
Mm-hmm. Mm-hmm.
So we're looking at just to kind of summarize this, we're looking at a 17-year-old who had not been able to have a full solid meal in 3 years because every time she ate, she experienced this hypervisceral sensitivity that it was excruciating pain where she would double down, cry, nausea, vomiting. It's just, and I remember her telling me that from the central port, from her line, she had sepsis 7 times.
Right. So exactly to your point, she did not. So first we started with, like you had mentioned, a nasal tube, right? A nasogastric going into her stomach. Because all of us, when we chew our food, the receptacle that receives your food is your stomach. She didn't tolerate that. We tried a nasojejunal. We tried the gastric port, and she wouldn't tolerate that. And the reason was, like you stated, like debilitating pain. Like eating is something we, enjoy. People like to eat for pleasure. And for this poor girl, anything going into her stomach caused her so much pain. So we had no option. So even the jejunal port, which was going further into, so we were like bypassing the stomach and trying to feed directly into the small intestine to help alleviate some of that discomfort. Even that was not going well for her. So we had to resort to delivering nutrients through her blood, which is through a central line, which is it's a deeper access point. And those central lines or ports, there's different ways to describe them. They deliver TPN or nutrients directly, glucose, amino acids directly into your bloodstream. And when you have these pieces of plastic sitting in your blood vessels for long periods of time, they can get infected with bacteria. And because you're sitting directly in your bloodstream, the bacteria streams into your blood, and that's called sepsis, and that's called a line infection, and that can be life-threatening and very, very serious. And so she, like I said, the more you do, the more complications you create. So, we had placed these central lines to deliver TPN and IV nutrition, but these lines would get infected frequently. And then we were dealing with these life-threatening infections into her bloodstream, which is the sepsis and the complications. And yes, she had many of those. And eating was just, a very difficult and painful experience for her.
And that's what I want to point out. And this is one of the sweetest souls on the planet. With Dr. Safder, I had such a mutual bond, this beautiful, beautiful soul. So she's going through all of this, and every time she's highly, highly stressed. So she was telling me this, that she had the last rites read over her. She doesn't remember that, but her parents were telling me this one time, what it was like to have to read their last rites over their child from these infections. But you were following, obviously, to the T, the protocol, but there's so much mind-body connection things happening at this point in time. And so much of the miswiring with the brain-gut interaction that she'd gone through the years of not being able to eat for 3 years, the stress that her body's under, not even be able to fight off infection. So it's what I want to point out to the audience is that's how much the mind-body plays a role in this when you're so stressed and you've got so much going on, no matter what medical interventions are done to the exact precise T, when the body is going under so much stress, it starts to have an impact on whatever medical protocol is being followed, correct?
Absolutely. Absolutely. And I think for her, it's important to recognize that we had the symptoms, right? These very difficult to treat symptoms where she cannot tolerate being fed into any part of her GI tract. But then we had testing, which I had done, what I do, motility testing, because I'm like checking. I was like, what, is this not working? Is this not working? What part is not working? and we're kind of black and white when we look at that. It's like, okay, there is movement, there is no movement. Okay, physiologically, this part seems like it's functioning, it's not. So we weren't getting a tangible answer in terms of the physicality of, her gut's not moving or what have you. And the gut and the body in general, it's amazing. I mean, there is such a thing as use it or lose it. So when you don't eat over long periods of time, when you are not stimulating your gut, that normal stimuli is lost and you start to then lose function, not primarily, but secondary to not using your gut. So secondarily, because we're not feeding the gut, there is no stimuli, we're not putting anything in, the gastroparesis and stuff, and the chronic constipation and the slowing of her motility was also secondary to a lack of stimulation, right? So it's like chicken or the egg, like what's happening? Like we have these symptoms, we're not able to eat, and the less we eat and the less we stimulate our gut, the worse our gut gets. And so that was kind of where we were with her, because I felt like through her testing, there was her body could generate motility patterns and was capable of, but her pain was such a complex part of her symptomology that if we couldn't get her to be able to navigate the pain part, we wouldn't be able to advance any feeds for her.
And I remember in the phone call, if I remember this correctly, you were saying that you were in consideration to sending her for a stomach transplant in Miami?
Yes. So when you reach a point of what we call enteral failure, so enteral failure is you're unable to deliver any kind of nutrients into your GI tract. You're unable to, enteral nutrition is you're unable to give any nutrients into your GI tract, and you have become TPN dependent, or you are 100% dependent on parenteral nutrition. And you are to a point where you've had multiple line infections, multiple sepsis, life-threatening infections. The effects of TPN and parenteral nutrition are then also felt on other organs like the liver, just because it's not a natural way to feed. So when you start to see complications from your parenteral nutrition delivery on a patient, you have to do some sort of salvage. And so one of the indications for bowel transplants is enteral failure. And that's where she was. She was at enteral failure. She had every complication known from her parenteral nutrition, and this was not going to be sustainable to her. So either she would die from complications of parenteral nutrition or die from enteral failure. And so the consideration of doing organ transplant is like, okay, if these organs are not working, if the sensory or the motor components of these organs are not working, transplant an organ that's not working so we can restore some of the functionality. And so that was we were at that point with her, with consideration of such, options. And I don't, again, for the audience, transplant is not a joke. And it's not easy. And yes, you are transplanting an organ, but it's not like everything's hunky-dory after that, because transplant medicine is very complicated, because you're trying to put an organ into somebody's body and their immune system has to accept it and not reject it. And so there is a lot of transplant medicine, which is a lot of immune monitoring and so on and so forth to prevent, organ rejection. So it's not an easy fix, is the point I'm trying to make.
Yeah. And I remember when you called me, and I was actually swimming in the pool, and I was pacing back and forth, and I was like dripping wet from the pool, just so eager to learn from you. And I heard your voice crack, and you said, "This is her last hope." And I remember in that moment being like, I said a prayer to God. I'm like, all right, let's figure this out. Like, I very rarely get a call from a physician that says something to that degree. Like, it just, that's a pretty intense call to get. And I get a little choked up thinking about it, because it was such an amazing process that happened going through that with her and watching all that you all have done. So when you say that, and I remember saying, gave me a crash course on it. My biggest concern at that time was this patient willing? was she willing? Because now her life is on the line. And to point out to the audience, this is a beautiful. By the way, this child was a competitive athlete. She was exceptionally brilliant, exceptional grades, loving, supportive family. This was just an exceptional human who just life was just slowly started to deteriorate to the point where she's on a stomach transplant list. And so when you asked me about clinical hypnotherapist, I remember just saying, okay, give me a crash course in GI. And you gave me this 30,000 foot view of like, I said, what optimal outcome do you need to see? And do you remember what your answer was? I said, what is your optimal outcome you need to see with her? There's a whole conversation almost memorized in my head because it was such a big moment in my life.
I don't remember, but I know I needed her to be able to eat and tolerate feeds. Like I knew that was like, we were at that point with her. So no, refresh my memory. What did I say? I was pretty different back then.
Yeah, you did. You taught me how the different sections of the DI track, and then you said ultimate outcome is she can eat and retain. You said the word retain nutrients.
Yeah.
That was the key word I used for hypnosis. So I'm going to fast forward it to people for what happened with the miracle patient. You can see why after her, I'll briefly say, after her third session, she had her first scoop of peanut butter. And you had pulled her tube right before my third session with her. You're like, we got to go to the baseline is what I'm presuming you were thinking. Let's just give it all we can.
Yep. 100%. I mean, we were at that point, and I remember, and like you said, she's this joyous young person. And I told her, I said, you have to try this, and you have to really go into this with an open mind, and you have to listen, and you have to get through this, because if you don't, these options that are on the table are not looking good for you. So we were at that point, and your heart just hurt for her because everybody who met her felt for her. And it's not like she didn't want to get well. She wanted to get well. She was stuck. She was stuck.
Yeah. Oh, and that's what I want to point out when I talk about other podcasts. This beautiful soul human wanted it. So by the third session, I'll just briefly summarize. First bite of peanut butter. By the fifth session, she always wanted to eat at Chick-fil-A again. So I hypnotized her. We went to Chick-fil-A, and she had her first meal out. So that's what I saw on my end. We did hypnosis. For her, we used something called neurotheology. We brought in her faith. We used a lot of music. But it was more about her willingness and her determination to get better, which is what did it. And how would you describe her today, as you know her today?
Amazing. I mean, so she has graduated out of the pediatric realm, but I kept in touch with her. And very interestingly, I ran into her mom just randomly out in public. And she heard my voice. Like we hadn't seen each other. We heard each other's voice, and we just turned and we're like, oh my God, how are you? And she's pulling out pictures and showing me pictures. She's married with an adorable child, and it's joyous. Yeah. She works a full-time job. She's actually working in the medical field. I think she does like something in surgical pre-op areas or something in that, I think her mom said. So she had I think she had a COVID wedding. So I saw some of her wedding on Zoom because we all got like Zoom invites to it. So she's doing amazing. She's healthy and she's thriving. She's tube free, central line free, enjoying meals.
Yeah. And that's the whole point when you were describing earlier is the brain gut interaction. The gut has a second brain in there. And once we tapped into what I call secondary gains, attachment styles, emotions, and that's all separate podcasts. So now I wanted to tell the audience, now you get the concept of why it's called why we call her the miracle patient. It went from extreme. So kind of backing into a little bit, and you described the different features of gut-brain interaction disorders, and you describe motility. Can you briefly describe like the sensation and the other brain gut dysfunctions?
Sure. So disorders of brain-gut interaction. So there's a brain and gut. So and I'm going to try to, summarize it for our audience, but part of our gut besides motility. It's a bidirectional organ. So when I say bidirection, think of your messages going from the brain to the gut and messages going from the gut back to the brain. So there's, it's a two-way highway essentially. And it's complex because it's neurohormonal. So there's an interplay of nerves and hormones that are neurotransmitters that actually deliver messages throughout your brain and your gut. And think of your gut as a tube. Okay, a tube that this is one end of the tube, your mouth, and the other end is your bottom, and it's one long tube. And the job of this tube is to move and push. But remember, that tube is lined by billions of nerve cells, and these nerve cells can feel. There's nerves do two things. There's sensory nerves that can feel things, that detect sensation, that get stimuli, that pick up signals. And then there's the motor part of the nerve, which tells us the action or tells the muscle what to do. And so if you think of this long tube, it is a tube that's lined by muscle. And this muscle receives signals from the nerve, but the same nerves also carry signals from this organ, the gut, back to the brain. So it's a two-way highway. And what happens in disorders of brain-gut interaction is the sensory component, meaning what the gut feels, is very amplified. Just think like the volume is turned on really, really high, right? The signals are blaring. Like if you wonder if your brain was hurting, like you had a bad headache, or you would cry. Like imagine the gut's trying to cry because it feels pain, but the gut can't cry. The gut is going to exhibit pain and dysfunction in the symptoms that the GI tract does. Like, so when you have this normal, physiology, and when this is dysregulated, you're going to have these abnormal signals, abnormal symptoms that are going to, crop up. And so the medical term is visceral hyperalgesia. So viscera are organs, and hyperalgesia is feeling an elevated sense of discomfort to stimuli that otherwise would not be painful, because your gut is constantly moving. There's a constant maybe squeezing or contraction motion, right? And to most patients who don't have DGBIs, disorders of brain-gut interaction, they may not even be aware of these motor patterns. But in somebody who has visceral hyperalgesia, that contraction, that squeeze feels like a painful squeeze, a painful contraction. And this message is being delivered through the sensory part of the nervous system, the enteric nervous system, to the brain. And the brain is the central processing. The most powerful organ in your body is the brain. And this brain receives these signals, but the brain also processes complex, your cognition, your how you deal with emotions, how you deal with other sensory stimuli. And the brain is affected by a lot of things: sleep, mood, stress. And so this is where all of this processing occurs of these signals. And then there is, again, efferents going from the brain back to the gut, telling the gut what to do. So it is, like I said, a complex biopsychosocial model. So we know that the biology of what the gut feels, especially when the signals reach the brain, and then what happens psychologically at the brain level, plus the added stressors of what's really going on in your life, and the social stressors, and people deal with stress differently. You have people who have catastrophizing behaviors and social isolation, and how you deal with when you don't feel good. That adds another layer of complexity to the problems. And I don't want it to sound, and this is really, really, really an important point to our listeners, it's all in your head. This is not what disorders of brain-gut interaction is. So it is not like, oh, this was in her head the whole time. There was nothing wrong with her. There is something wrong. There is something wrong in the biology of how her gut was functioning. The altered motility, altered sensory pathways. There's a reason why those pathways are altered. Why are her sensory signals so amplified? Why does she have the hyperalgesia or the intensified pain signaling? Because there was possibly some insult to her gut. We have so much research that proves over and over again that the gut microbiome, inflammation. I just got done saying that the gut is a neurohormonal, uses neurohormonal pathways. So we have neurotransmitters, we make cytokines, we have inflammatory pathways. Our gut, especially the lining of our gut, it's kind of like a barrier from the outside. We're constantly eating, ingesting bacteria, viruses. There's thousands of antigens that are, our gut is like the first line of defense, right? But if that gut wall is compromised, if those tight junctions between the cell layers are compromised and allows for these stimuli to enter this rich vascular area right under the lining where all of your immune system is, and it's getting activated and there's immune responses that are happening, there is something happening at the level of the gut, some insult that's happening, something that is not optimized or something that's damaged. And that's why we see a lot of post-infectious disorders of brain-gut interaction, meaning you got a really bad infection, of some sort, and your microbiome is altered and inflammation occurs and immune activation occurs and your body doesn't know how to shut it off. And this feeds into that hyperalgesia and so on and so forth. And even though the precipitating insult, maybe that initial infection or what have you is now gone, here we are still lingering with symptoms of that insult. So like I said, it's complex. There is a neurobiology to why disorders of brain-gut interaction occur. At a gut level, changes do occur and they're tangible and they're measurable. But it is an evolving science. And while we understand it and we're better at defining it, there's still a lot that we're learning, especially given the complexity of the microbiome.
Next week, we will continue this discussion, and Dr. Safder and I will take a deeper dive into what exactly are the insults that she was referring to, such as emotions. So if you recall from episode 1, emotions are the glue that bind the mind to the body. Emotions are released from the 60,000 or so thoughts we have a day. They, in turn, infiltrate the roughly 30 trillion cells in our body, including the GI tract. So we'll continue to explain more about how emotions and limbic system are at interplay with the GI tract, the biopsychosocial model. So to summarize it, ants create emotions that cause a trigger, that activate the autonomic nervous system, creates a limbic response of fight or flight, or frozen. And all this culminates into the brain-gut interaction disorders like IBS, Crohn's, dyspepsia, abdominal pain. We will get more into how attachment styles, overachieving, chronic invalidation are all major players in the brain-gut interaction disorders. And my book explains all of these theories and methods in greater detail and what you can do about it for yourself and for your child. So I've got the 2 books coming out. One is Empower Your Child to Heal, and the other one is Empower Yourself to Heal. And it's going over all of these answers of all these things that no one's really talking about, brain-gut disorders, chronic invalidation, when medical tests and medications aren't working. And if you recall in the first episode, when I talked about being in a wheelchair, and today we went over the miracle patient and then the other patient who had heightened pain responses. And I have hundreds of these cases that there is hope to healing when you look outside of the box. That sometimes there are answers that can be explored within the mind-body connection. So I do have a workshop and a retreat this fall. You can go to drschuyler.net and get some free downloads, some free information. A lot of really cool little sneak peeks into the book will come out in the monthly newsletter. And I send you all abundant blessings, beautiful souls. Thank you for your time. I feel so grateful you have listened to the end. When we begin to understand how our body manifests stress, trauma, depression, anxiety, and even unexpressed emotions, We then create a space, a bandwidth in our minds to begin to heal our bodies. Healing is a decision, and I am grateful for yours. Abundant blessings, Dr. Schuyler.
To learn more about the work Dr. Schuyler is doing, please visit drschuyler.net. That's drskYler.net. And remember to subscribe to this podcast wherever you like to listen.
Produced by Audavita Studios. Connect your voice to the world.